Good morning, friends, and welcome to this ISCCM Common Academic Program on renal issues for the intensivists. We actually probably are unfortunate that every time we get a chance to do a program, we lose the opportunity of having a physical interaction with all of you. But nevertheless, let us get on with the virtual program on this topic. And I thank the ISCCM Hyderabad chapter for giving my institute and my team an opportunity of participating in this program. What I'm going to talk to you about in the next 15 minutes or so is a problem which most of us would face every day in the intensive care unit for our patients, and we end up having a diagnostic and therapeutic dilemma about what is actually the outcome, or what is actually the plan of action for a patient with decreased urine output or oliguria. So let's look at a case scenario which is not very uncommon in the intensive care unit. A 24-year-old male with a no comorbid problem comes to us with having been involved in a high-speed motor vehicle accident. He sustained chest trauma with multiple rib fractures, blunt abdominal trauma with liver lacerations, hemoperitoneum, pelvic trauma, and fracture of the right femur shaft. He presents to the emergency room in shock with hemoglobin of 6.4 grams per deciliter and requires invasive ventilation for hypoxia and is also having hematuria. So this patient was resuscitated with crystalloids, got blood transfusion. He undergoes a contrast CT of the chest, abdomen, and pelvis, and undergoes an emergency laparotomy as well. On table in the operating room, he was given ceftriaxone and amikacin as decided by the orthopedic surgeon. He returns to the ICU on vasopressors, and his urine output during was about 100 ml during the surgery, which lasted for about 2 hours and 45 minutes, and then 20 ml per hour for the next 4 hours. So obviously, this patient has sustained a lot of insults to the kidney. He's hypoxic, he's hypotensive, he's got contrast, and he's got aminoglycoside, and is on vasopressors and had a prolonged surgery time in OT. So the urine output seems to be low. So does it fit into the definition of oliguria? So oliguria by definition is the consensus opinion about oliguria is it is a urine output of less than zero point 0.5 mils per kilogram per hour for more than 6 hours. There have also been a school of thought which says that a cutoff of less than 0.3 mils per kilogram per hour is independently associated with a postoperative AKI with an odds ratio of 2.65, which is very, very high. But oliguria has to be interpreted against the clinical context. For example, you have a diabetic patient who is hyperosmolar and was putting out 3 liters of urine at the time of admission to the hospital, but within 6 hours, the urine output fell to 1.5 liters in the day. Then, even though by definition it is more than 0.5 ml per kilogram per hour, there is relative fall in the urine output that should be investigated as a potential oliguria. Relatively reduced urine output of more than 0.3 ml per kilogram per hour is likely to represent a reversible physiological response to perioperative stimuli, including intravascular hypovolemia, hypotension, and the release of antidiuretic hormone in response to pain or other such stimuli. So what is the magnitude of this problem? Is it just a flash in the pan, or is it a persistent problem in the intensive care units? Nearly 30% of the patients who are admitted to a critical care unit have oliguria at the time of admission or develop oliguria within the first 24 hours of critical care unit admission. Nearly half the patients in an ICU will have one episode of oliguria during the stay in the intensive care unit, and mortality is higher in patients who develop oliguria with or without acute kidney injury. But your attempt to convert an oliguric AKI to a non-oliguric AKI by the administration of diuretics is not shown to improve outcomes. And oliguric patients in the intensive care unit, even after they recover their normal kidney function, are at a high risk of developing chronic kidney disease in future more often than those who do not have oliguria while in the intensive care unit. Let's look at the pathophysiology of why oliguria happens. Urine output is a function of glomerular filtration rate and tubular secretion and tubular reabsorption. Therefore, glomerular filtration being a direct dependent on renal perfusion, urine output is a marker of renal perfusion and therefore the cardiac output. Therefore, oliguria indicates a reduction in GFR, or it may reflect a mechanical obstruction to the flow of urine. So these are the two important aspects of pathophysiology of the genesis of oliguria in the intensive care. So our guy in the intensive care unit, he remained hemodynamically unstable for 2 days. Vasopressors were continued with multiple fluid boluses, and the ventilator parameters worsened. Intra-abdominal pressure increased, and he was noted to have rhabdomyolysis. So persistent hypotension, large volume fluid resuscitation with crystalloids, and possible hyperchloremia, hypoxemia, intra-abdominal pressure and in abdominal compartment syndrome, and pigment-related or protein tubular damage because of rhabdomyolysis have all added to a patient who already had risk factors for acute kidney injury. So when you look at patients who are oliguric, they may be hypovolemic, or they may be in pain, or they may have nausea. The hypovolemia triggers the renin-angiotensin-aldosterone axis, as well as activates the sympathetic system and causes release of antidiuretic hormone, whereas the pain and nausea in the intensive care unit can cause sympathetic activation and release of antidiuretic hormone. These are physiological responses to stress, so which produces the oliguria. Whereas in the intensive care unit, renal hypoperfusion, markers of inflammation like sepsis, nephrotoxins like this patient had contrast and aminoglycosides, and cast nephropathy like this patient who had rhabdomyolysis will contribute to acute kidney injury, which adds to the oliguria which has been triggered by physiological mechanisms. So when you have a patient with oliguria, how do you approach it? Although obstructive uropathy as a cause of oliguria is the third or fourth common cause of oliguria in the intensive care unit, the first thing you should need to exclude in an oliguric patient is obstruction, because your fluid therapy, your diuretic therapy, your renal replacement therapy will all be looking superfluous and a little stupid if your patient actually has an obstructed Foley's or obstructed prostate. So you use a point of care ultrasound and see whether there is an obstruction, which you can treat it. If there is no obstruction, then you do a hemodynamic evaluation, look at the map, look at the shock index, look at the medication history, look at echocardiography for cardiac function, look for evidence of low cardiac output, and look for evidence of septic shock and systemic congestion. So if you find hypovolemia, give the patient a volume challenge. If you find a hypotension, give the patient a vasopressor challenge. If you find a low cardiac output, give the patient an inotrope challenge. If you find as evidence of systemic congestion, give the patient a Furosemide stress test. So in this particular patient, the dynamic parameters were not suggestive of hypovolemia, and the vasopressors were continued. He remained oliguric, he developed hyperkalemia, and was therefore to be initiated on continuous renal replacement therapy. So in an oliguric patient, your first step is hemodynamic stabilization. That happens by ruling out hypovolemia, monitoring the urine output, targeting a mean arterial pressure of 65 to 70. If that doesn't happen, you look at response to diuretics and the Furosemide stress test. We'll discuss about the Furosemide stress test in a short while. You then look at biomarkers, which have a limited data in oliguric patients, but can indicate where the kidney function is going. You work up the patient for AKI with the blood work like serum creatinine, blood urea nitrogen. Look at the urine dipstick and microscopy, and look at urinary electrolytes and abdominal ultrasound. Look at the kidney size. We will have a detailed session on radiology for the intensivist also, so you'll know more about this very shortly. So after all this, you manage the patient and treat the volume overload. So what are the facts about volume challenge? when you want to give a patient who is hypovolemic a volume challenge, you tend to go with crystalloids. You need to go with crystalloids because starches and gelatins have been known to aggravate kidney injury in patients who have risk factors. If large volume fluid therapy more than 2 liters is needed, you need to consider balanced crystalloids. If there is no CKD and ARDS, the recommended volume of fluid to be given is 30 mils per kilogram, and you monitor for fluid overload by lung ultrasound and other parameters which you routinely use in the intensive care unit. But the reliance should be on dynamic parameters rather than on static parameters. But all patients who have got volume resuscitation, large volume resuscitation, should get their intra-abdominal pressure measured because we do not know at what intra-abdominal pressure the renal perfusion pressure actually falls down. Volume challenge is probably effective in those patients who get admitted to the hospital in with oliguria, but it is less effective in those patients who develop oliguria in the intensive care unit. So new onset oliguria in the ICU may not respond so well to volume challenge. What about the vasopressor challenge? Vasopressor challenge should always be considered in those who have fluids, in whom fluid therapy has been considered to be given and no more fluid therapy is considered to be needed. The target for vasopressor challenge is mean arterial pressure. We have already discussed a target of 65 is good enough. Other organ injuries have to be kept in mind while giving the vasopressor challenge, like brain injury and gut injury and cardiac injury. The choice of vasopressor is noradrenaline followed by vasopressin, and you titrate them to urine output and perfusion markers. That brings us to the volume overloaded patient in whom we want to know whether there is a renal reserve. That is judged by using the Furosemide stress test. The Furosemide stress test is a risk stratification to identify those who are likely to progress to higher stages of acute kidney injury. It tests the functional integrity of the renal tubule, but patients should be adequately filled before you try to use a Furosemide stress test. So an adequately resuscitated, persistently oliguric patient in whom inotropes, vasopressors, and fluids are not likely to be of benefit should be subjected to the Furosemide stress test. If the patient has not received Furosemide in the past, that is a Furosemide naive patient, you can give 1 milligram per kg of Furosemide IV bolus. But if the patient has received Furosemide in the past, you give him 1.5 milligram per kg bolus and then see what happens. If the urine output is more than 200 ml in 2 hours, the patient is supposed to have passed the Furosemide stress test, and you make a diagnosis of pre-renal oliguria, and the patient is considered to have a good renal reserve, and you give more fluids to the patient. Whereas if the urine output is less than 200 mils in 2 hours, the FST is deemed to have failed, and the patient is considered to have intrinsic AKI, and you consider early RRT for these patients. What about diuretics in oliguria? Diuretics are used under different pretexts. Some people believe that they produce direct renal vasodilatation. They may attenuate the medullary hypoxia by inhibiting sodium potassium chloride pump to reduce the tubular oxygen consumption. They attenuate the ischemic reperfusion induced apoptosis, or they mitigate fluid overload and accumulation. And this hypothesis of converting oliguric to non-oliguric AKI. Some of them are valid reasons and indications, some of them are not. So if you look at the clinical pharmacology of diuretics, spironolactone and eplerenone are the only drugs that act on the basolateral membrane. All other drugs need renal excretion. Most of them are protein bound, so they do not get filtered at the glomerulus, and the bioavailability varies, and effective dose of diuretic may vary in different people. So loop diuretics are the most potent and the best to be used. And in an intensive care unit setting, intravenous loop diuretics are used because of the reduced gastrointestinal absorption. The duration of action of loop diuretics is short, so repeated doses are probably needed. And if you want to give a longer duration, continuous infusion probably is a little better than intermittent bolus doses. Is there any advantage? So far, evidence has not shown much benefit in terms of giving an infusion versus intermittent dose, but the total dose of furosemide required to achieve equivalent negative balance is lesser with a continuous infusion of diuretic. So when you look at diuretics and an oliguric AKI, what is the understanding? Diuretics do not prevent AKI, so do not give furosemide to prevent AKI. They may actually increase the risk of AKI. The recent KDIGO guidelines recommended not using furosemide to prevent AKI, and they are also not useful for treating AKI. So diuretics should not be used to treat AKI except for the management of volume overload and for judging the renal reserve as we have described. And if a patient is on renal replacement therapy and is trying to put out some urine, giving diuretics to them will not help them in earlier liberation from renal replacement therapy. This is also have to be balanced with the fact that diuretics have a lot of side effects like profound fluid volume depletion, hypocalcemia, hyponatremia, hypokalemia. They can produce a contraction alkalosis and hypomagnesemia, and in the long term can produce hyperglycemia and ototoxicity. So they have a lot of effects which should warn us about not using them. So where do you use furosemide in your ICU today? For cardiac failure, during and after cardiothoracic surgery, for a fluid overload state, acute lung injury, and in patients who have oliguric renal failure to test the renal reserve. What are the pitfalls of using furosemide? The side effects we have described. The improvement in urine output may be interpreted as an improvement in renal function, which are not the same, which might actually delay the renal replacement therapy and increase mortality. The use of diuretic like furosemide will limit the use of urinary sodium to differentiate between intrinsic and prerenal AKI. High doses of furosemide can cause vasoconstriction, and there are a lot of interactions with furosemide. The caution I would like to make is do not use furosemide with contrast agents. Do not use in pregnant women with hypertension. Don't use in dehydrated patients to increase the urine output. Don't use it when other nephrotoxic agents are being given. And don't use it for increasing urine output in patients with myoglobinuria and hemoglobinuria. So in summary, oliguria is a symptom. A stepwise approach is advisable. Obstructive uropathy should be ruled out first with ultrasound. Furosemide stress test has specific indications, and only loop diuretics are effective in compromised patients, and diuretics do not alter the need for renal replacement therapy. Thank you very much and have a good day.